all we need. So Stacy, did you have open stuff that you needed to say, or did you want me
Just
to
welcome everyone to this ad hoc call of the Open Policy Learning Collaborative, formerly known as the Policy NRT. Today's call is being recorded. I did hear from a number of folks, particularly since this was just scheduled yesterday, that they couldn't make it but want to hear the recording. So we're doing that, and we're going to be sending that out. Please keep yourself on mute till you're ready to speak, but take yourself off of mute early and often, and feel free to use the chat. And with that, I'm going to turn it over to Sarah Holland with Virginia Health Catalyst.
Thank you, Stacy. Happy afternoon, everyone. Happy Friday from Richmond, Virginia. It is beautiful here, so I hope you all are having a similar experience wherever you are. Thanks for hopping on at a very last minute kind of ad hoc policy meeting, but we've got some great news. So we wanted to make sure that we had the opportunity to, one, hear from folks that are in the know, take a moment to celebrate collectively, because we don't often have great news on this call. So it's nice to be able to talk about some positive things. And then one, talk a minute about next steps and about kind of what the role of this group is going to be in terms of getting some of that information out and moving a lot of those next steps forward. We don't have to make a ton of decisions today. This is mostly just about making sure that everyone's up to date on the latest information and understands kind of the first round of communications that are going to be coming out and how you can share them. But I feel like I have to give a huge shout out to Melissa and Weiwei, and I know I'm leaving other people out who've done an amazing job to get this through, but those particular standouts, one, are front and center in my camera, but I also know that this has been a years long commitment that they have been working on, and thank you for seeing this to fruition so we can now move to implementation. It's really exciting, and I'm just glad to know you guys and glad to be in the community with you, and really appreciate your efforts. Gonna start off, say what the win was. Oh, Stacey's like, say what the win was. Okay, the reason we are gathered here today is because the rule came out that is going to enable Medicare beneficiaries to have access to a bit more dental coverage, those with that are being tied to medical issues. And Melissa's going to talk about all the details of it, and I'm sure Weiwei will probably weigh in as well. So with that, I'm going to hand it over to Melissa and stop talking.
Thanks, Sarah. And yes, Weiwei, definitely jump in. What I'm going to give a little bit of an overview about where we are and what this means, and then I have some slides that have specifics about what was in the rule. And then I do want us all to have a discussion about kind of where we go from here. But Weiwei, as many of you all know, Weiwei and Center for Medicare Advocacy have really been in the weeds on this particular issue, building the legal case for it, building the clinical case for it, doing just the deepest legwork. So I want to reiterate Sarah's thanks to Weiwei and to all of you that also submitted comments and have been helpful in getting this across the finish line. This is a big moment for all of us, but it wouldn't have been possible without the work that CMA and others have been doing for a very long time. So before I bring up my slides of what's in the rule, I do just want to take a moment to say, this is a big deal. You know, this rule is not perfect. There are things we wanted in it that are not there, and there are things we're going to push for improvements. But to get the administration to codify the fact that they believe in this legal scenario where Medicare can pay for some dental coverage in certain clinical medical scenarios is a real recognition of something we've been trying to advocate for years, and they open the door to making this more robust and stronger over time. So what we have is a regulation that was tucked within the Medicare physician fee schedule, which is a big catch-all rule that comes out every year. And because of that, that means that, you know, we have an improvement that happened right now, and then every year from here forward, there will be opportunities to make this stronger and more robust and give the administration the evidence they need to cover more things. So all that to say is I hope that you all take a moment to recognize that this is a big win for oral health, even if it's a limited benefit. And I'll go through the specifics in a moment, but I think we should all be really happy with the fact that this happened at all, and continue to lift this up, and take a victory lap. So before I get into the specifics of does anyone have any questions just at the outset of the overview and where we are? Okay. Let me bring up these slides, which, let me tell you, are slides that break all the rules. They have a lot of words on them. They're very wonky, but they are for this group, and they will hopefully be a helpful guide to start from. And we're starting at the end. Okay. But really all I had time to put slides on together for is exactly what the rule says. And I'm more than happy to have anyone who's worked on this weigh in as well. But I think the most important pieces for folks to know are, first, what this rule says it covers. What it did was it created a coverage standard, so a rule by which we will decide if certain clinical scenarios meet the criteria laid out in the standard. So those words didn't probably make a ton of sense, but basically this is the basis by which we're going to determine if something is medically necessary or not, starting now and going forward. And what that standard is, and as laid out in this rule, is that Medicare can make payment for dental services that are inextricably linked to and substantially related and integral to the clinical success of certain other covered medical services. That is quite specific. It's a little bit more stringent than we hoped it would be in terms of how many different qualifiers there are. But it is very much an indication that we can take this as a baseline and continue to apply more and more scenarios to it. Now, what the rule did, in addition to putting up that standard, is saying these are certain examples of clinical cases, clinical medical scenarios where dental care is inextricably linked to and substantially related to the integral clinical success of. And there were some that were already in Medicare policy, though not in statute. So that's what this first list is here. And then there were some new examples that were added that broaden this to some more commonly occurring clinical scenarios, including organ transplant, cardiac valve replacement, or valvuloplasty procedures. They also are going to be implementing or adding the example of a comprehensive workup prior to head and neck cancer treatment and including dental care in that next year. So that is what it says. And what essentially that means is we have a new coverage standard and some very specific examples of where it will apply. And these are helpful. These will help a good number of people get care that they really, really need. But part of what's really exciting is that there is a clear process for additions and that there is a little bit of flexibility within this. So one of the things that this rule states very clearly is that CMS is interested in getting more evidence on a number of specific scenarios, including joint replacement surgery and chronic disease management, and a few things that they had gotten some comments on in this comment period, but also just generally on anything that the interested parties feel meets this new standard. They want to hear from us, and they're going to be doing their own research too. So they want for interested parties to submit evidence to them of additional places where this standard could apply by February 10th of each year at this particular email address that they will consider for rulemaking the following year. So, I think you can submit submissions anytime throughout the year. They may even consider things outside of that window, but they guarantee that they will consider anything submitted before February 10th of a year for the next year's physician fee schedule. And they also made it clear that they will be doing their own research on how to potentially expand the use of this coverage as well. And then one thing that is really important is that the Medicare contractors who process claims are able to determine on a claim by claim basis whether a patient's circumstance does or does not fit within this new coverage standard. Now, I'm happy to defer to Wei in the specifics of how that works, but I think what this is helpful for is saying, a coverage standard is a coverage standard. Examples are examples. Theoretically, claims processors could determine things as meeting the coverage standard without being so stringent along the examples. Now, that's probably how they will do it. That's the best way they will have to determine what does and doesn't meet it are those examples. But there is a nice amount of flexibility with that does help us not read this too narrowly. So that's generally what's in it. Wei, I would love to turn the mic over to you for a moment if there's anything you'd like to add or clarify.
Okay, so thanks, Melissa. Thank you for just leading us through this to this result that we have. I mean, it is a great first step. It is a major milestone, but so as a Medicare advocate, my first thought is beneficiaries. And, I just want to caution everybody to be really careful about how we talk about this coverage, this new rule. We don't want to give people the wrong impression about what will or won't be covered. So I think, the language we use, in emails, anything that goes out, we need to be really careful not to let people think that, Medicare is now suddenly going to cover the universe of medically necessary dental treatments. Believe me, already because of all the work that we do, some of the things we put out, give people the impression that, Medicare should cover X, Y, and Z and will cover it if you, appeal. Or that's not necessarily true. So it's just very important to wrap our minds around the fact that, this is what we know will definitely be covered starting 2023, are the exams and treatment to eradicate infections prior to organ transplants and cardiac valve surgeries. And in 2024, there will be similar coverage for dental care contemporaneous, prior to and contemporaneous with head and neck cancer, though we don't really know the full parameters of that yet. Beyond that, though, there is a coverage standard, this inextricably linked one that Melissa mentioned, and that's not unimportant. And it's not unimportant that the agency has said that its contractors can apply that standard. They don't have to adhere to these examples that the agency is codifying, putting into regulation. Those are just examples of what, the agency recognizes outright, as being coverable under the standard. The regional contractors that process claims, they can decide on a case-by-case basis whether somebody's dental treatment meets that criteria of being inextricably linked, substantially related, and integral to the clinical success of a covered medical treatment. So, but that might not be helpful or give beneficiary a lot of confidence that they're going to get coverage, when they actually need and get a service. And actually a provider, a participating Medicare, Medicare participating provider is not going to have confidence either that they're going to get reimbursed for providing care. So, that's why we have to be very careful. We can't just say, here's the standard, and if your dental treatment falls in that standard, you're going to get covered, because it's not a sure thing at all. And it's not a sure thing that your provider is going to believe that they will get reimbursed by Medicare for it. So that being said, people can still try. They can say to their provider, in case their provider, and remember, it has to be a Medicare participating provider. They can say, this is the standard now. Please, would you submit a claim to Medicare for this and help appeal, for reimbursement? If you really believe, you and my other physicians really believe that this is inextricably linked to the clinical success of, let's say, the person needs dental treatment to eradicate infections before, let's say, treatment for stage 4 breast cancer or prostate cancer, so if they can, really support that determination and bring it to the Medicare contractor that is going to process this, usually each contractor, they have medical directors who, can sometimes look more closely at the medical records and talk to the doctors and say, yeah, actually, this is inextricably linked and, integral to the clinical success of the medical treatment, this dental treatment. That can possibly work, but, it's not a sure bet. So that's why this annual process that Melissa mentioned is very important. We need to continue to collect any data we find that supports why dental treatment is integral to in other clinical scenarios. It's going to take time. It's not going to be, immediate, but hopefully with, more big data about it and us being more vigilant about, identifying the data and like using it and, gathering it and using it over time, we are going to grow the coverage under this standard. So I don't know if that was helpful.
No, that's great. Thank you, Wei Wei. And so what I'd love to do now to kind of transition from, well, actually, there is one question, and Wei Wei, you may have thought about this a little bit, or maybe this is beyond where we are right now, but there's a question of how we expect this to affect patients on dialysis.
Yeah, I don't have a response to that right this moment. Maybe on our next call, I'll have wrapped my mind around this more. Yeah.
Then we'll go back to what I was going to say, which is I think where this leaves, there's the place where a couple things, there's a couple things that we should think through in terms of where this leaves us. One is we're still digesting this rule and figuring out its implications especially for beneficiaries and what, who will benefit from this, who won't benefit from this, how it affects certain people in certain scenarios. Like, I think that's something we still are thinking through. And then there's a couple of so that's a big piece. But in the meantime, there's several categories of that we need to address. One is we're in a really important political moment with this rule. And as advocates, when we're talking to folks that have championed oral health and have moved things forward, this is really important to lift up. We definitely want to be very clear about our audience and not taking this as too big of a win in how we're communicating to beneficiaries. We need to be very clear in how we're talking to Medicare enrollees and the general public about what is and is not covered and how that will work. But I do think ensuring that the Biden administration hears that this is important and that this is a great step forward, is critical, as well as the folks who supported this from the congressional side. I know a lot of us worked with our members of Congress to sign letters and to lift up this issue. So making sure they hear from us too is important, and thanking them for this step forward. And then another piece of this will be, as Weiwei kind of alluded to, ensuring that there are providers that can do this, that both know that this rule exists, are enrolled in Medicare, and have some level of confidence that the procedures they're doing fall under this standard. So, and then I kind of already said this, but the education piece of beneficiaries is huge too. There's a lot more to do to advocate for improvements to the rule and collecting that evidence. So that's a really important thing for us to start thinking about almost immediately, given that we have an opportunity to submit more information before February 10th. But also we recognize that that actually may result in us engaging with partners more than us doing it ourselves. You know, medical specialists and clinicians are often the ones that they want to hear from in the research. They kind of backs it up. So that's generally where we are, but I know there are some questions, and I'll stop talking for a moment to see what folks want to raise.
Melissa, Steve has a question he'd like to pose.
And my can you hear me okay?
Yep.
Yes. So my question may be a little naive, but this was when I was still at the ADA, it was an issue for me then, and it remains an issue now. I've always taken great umbrage at the fact when the ADA or even CMS wants to say these diseases are acceptable, these are not. And it's like, I'm sorry, show me your license. I have a license to practice. And my thought is always, so Weiwei and Melissa, my question is, if I had a patient that I truly believe the dental care was medically necessary for the overall health of the patient, if I'm willing to take the time, even if it's not a covered benefit, to write a prior authorization, several things are happening. I expect it to be denied the first time. I will redo it again. And I always make the assumption then, when the insurance company or a private company, a public company says, no, we're not covering that, they have taken the risk upon themselves. If something bad happens to that patient, I think they have set themselves up for liability. And I do think as we move forward in this, small steps, I do understand. But I do think we should be working with the third-party payers so that when people like myself do these prior authorizations in a broader spectrum that still aligns, that we are gathering data there so that we can use it collectively to actually make our case. I think it's important to do this for the overall big picture, but we address the needs of individuals. And I think we have to do that. And I was constantly slapped back by the ADA, and I didn't care because I have a license. So am I crazy, or is my thought somehow mistaken?
And I'll invite Weiwei to add in, because I think you're not crazy or mistaken in that that's the right thing to do. And I do think working with the third-party payers to encourage them to apply this as liberally as possible is necessary. I don't know what constraints they face within the bureaucracy of Medicare. Like, I think that is really where we're ultimately coming up on the problem, is that Medicare has this statutory exclusion that says 99% of dental care is excluded from medical care. You can't do most things in dental care, and that can be interpreted to mean absolutely everything. And in this case, they're saying no, this essentially, this treatment is part of medical care. And so therefore the dental care is covered. And in order to be able to continue to make that case, CMS has to abide by very, very stringent standard and by very, very stringent level of evidence that has to be there. So, you know, I think that this is narrower than we want it to be. And one of the ways to continue to push for its broadening is to continue to push on sort of the claims processing front as well. But I do think the constraints we face are significant. And I welcome any Medicare experts to weigh in more deeply.
I mean, I think what you said is true, and Melissa, and also Steve, that just one thing about Medicare is that Medicare, although it will only cover things that are medically reasonable and necessary, it by no means covers or has to cover everything that is medically reasonable and necessary. So, you know, even if, you know, there are administrators at CMS who believe, yes, you know, there's no doubt in our minds this is medically reasonable and necessary, the program doesn't actually have to cover it. So cover everything that's medically reasonable and necessary, which is why we're, you know, it's a great thing that we have this process and the new rule where they will continue considering things each year. They're saying that they're going to do this, and that's a huge step. I mean, otherwise, you know, you could present all this clinical evidence and they wouldn't have to even consider it. But they're saying now that they will. So yeah, I think the strength of the evidence is going to be really important. So.
Yeah, and Steve, I see your point about political power that older adults have too, and that is really important, both in that you know, we know Medicare dental was one of the #1 things that didn't get moved in legislation last year, that what voters wanted, and particularly older voters wanted. And so, to get a little tiny bit of political payoff from this minimal rule change is good, but I think it also is one where folks will say, that's nice, do more. And I think we need to make sure that's part of our role is keeping that message going. I see we have a question from Gary in the chat that says, was there an exceptions process prior to this rule? I think you mean, was there sort of a way to determine medically necessary before? And there was, but it wasn't codified in this way. And Wei, you can speak to this much more deeply than I can as to exactly what was there and what wasn't and how it worked in the policy manual versus being codified.
Right. I mean, the only exception to the exclusion of payment for dental was if a person received a non-covered dental service. So anything in the mouth or, you know, anything relating to the teeth or supporting structures at the same time that the dentist was performing a covered procedure. So it was really limited to procedures that involved repairing the jaw or removing a tumor. You know, if the person needed some kind of dental treatment that was integral to that other treatment that the oral health provider was providing that was covered, you know, that was the only exception pretty much.
Are there any
Thank
more
you.
questions? Go ahead.
I think that really speaks to how significant of a change this rule is.
Mhm.
Sorry, Sarah.
I was just asking if there were any more questions. I'm wondering if folks want to move into next steps, understanding that today is not about drafting the next policy advocacy initiative toward improving this, but really thinking about, given the information we have, given the fact that our we are diving deeply to understand this as deeply as we can so that we're communicating about it well. We definitely, well, maybe I shouldn't say we definitely, but I think the opportunity is we need to get in front of the communication so that we are sharing the rule change clearly so that we can celebrate with our partners and also make sure, I think Weiwei, your point was spot on, that the takeaway from this isn't, oh, hooray, now we have dental and Medicare, I'm gonna go to the dentist immediately. So I think there's some short-term communications that need to happen pretty quickly. And then I think, or I would suggest that we also think about just strategically kind of next steps from the ARM in terms of the advocacy that needs to go forward to continue to improve it. And then what steps need to be happening with regard to the implementation of what we have now. So, you know, what kind of communication do we need to make sure dentists have, consumers have, and things like that moving forward. Does that kind of general allocation of next conversations make sense to folks? I'm looking at Deb's question. You're spot on about needing to make sure that we're building on stuff year after year. Stuff is such a bad word. If my child said stuff, I would be like, be more specific.
I do think there's a short-term communication piece, but one of our immediate things to start thinking about too is exactly, Deb, the question you're raising around, okay, what do we need to have in place to keep making this more robust over time? And I was trying to pull up the language in the rule really quickly, but failed because it's 3,000 pages. About exactly what they're looking for. They are fairly prescriptive about they want clinical evidence, and they want certain types of very clear clinical evidence that is up to their standard basically. And so, you know, if you in a final rule, the administration has to report what commenters generally said and their response to those comments. And there was quite a lot in this final rule that said basically, like, we really appreciate that people commented to say that this thing should be covered, and they provided some evidence, or they provided anecdotes, or they provided sort of their own ideas around this. And it was very clear that, like, they are looking for a very high threshold. And to be honest, part of this is always the case with how rules are written, in that, you know, they need a very high standard of evidence, but also in this particular administration, they are very cognizant of protecting themselves from lawsuits and legal appeals and things that they know they won't necessarily win on as things move up the chain, up through the Supreme Court. So this is maybe not one that would go, get appealed in that way, but I do think part of the need for this is clinical, but part of the need for this is political, and they have to hold a really high standard into what they add in to regulation.
Yeah, I think that's absolutely correct. One thing though, maybe others know better about this than I do, but my concern is just that the data they're looking for, we might not have it in so much of it in America because, dental has been outside of, public health. So we just don't have the big data that links oral to systemic, so I think we need to let the administration know that our data is limited precisely because Medicare and much of Medicaid does not cover dental. So I think we should encourage them, to look outside of America, and maybe there are other countries that have done great research on the impact of dental on other medical treatments, and see if they can, reasonably rely on other, data from outside, because that's the part of the problem. You know, we don't have strong data precisely because of the division between oral and medical and overall health. So
And one thing that Wei, you and I haven't talked about, but that we should also talk about, not necessarily do, but is, there are things that CMS can do in terms of demonstrations and data, data generating activities that they can take on. And so if there are areas where we think that it'll be particularly hard to find the evidence, encouraging CMS to take those sorts of actions is helpful. Now, if there are things where we think the evidence already exists or is close, we don't necessarily want to do that, because that could, be a 5-year demonstration project, and that means they're going to wait probably until that's complete before they add something in.
Has there been, like, during this multi-year initiative to get where we are today, in terms of pulling that research together, was there, and I mean, Wei and Melissa, was there like an ad hoc group that was doing the lit reviews and pulling all of that together? And does that group still exist to kind of continue the work and continue?
Yes, that group hasn't even gotten back together yet because it's just happened, but there is a coalition-ish thing specific to this issue that's been strategizing the whole time. It includes a lot of clinicians, including a good portion of the Santa Fe group, but also folks that have deep connections with a whole bunch of medical specialty organizations. And so that has been the group that at least, really focused on this between when the proposed rule came out and now. And we've been building some of that evidence over time regardless, but I think until we had the proposed rule in front of us, it was hard to be specific enough to know exactly what was needed. And so I think that group still exists. They're certainly going to be working on this, but it could be more robust.
That was more my question. Like, we certainly don't need to create another group to, be friends with the group that already exists. But if you guys have a good sense of what expertise would be really helpful to add to that group, I would think that the folks here would be helpful in being able to identify who those people are. Because to your point, we all send in comments, but Virginia Health Catalyst, we're not clinicians, so they were very like, we think this is a super good idea. Here's some
Which, to be clear, is still a good thing to do. That is still very helpful.
No, I know.
But yeah, and that's a great question, and one that I don't think we have the answer on today, but is one we should certainly come back to, because I think that's what this group will kind of reset on. Because I think the other thing too is we knew there was going to be a high standard, but we didn't know how high. And so that group pulled together a lot of things, but there were things that didn't get taken up that we may have thought were closer or easier lifts. So we now, I think, have a better sense of where we need to build.
So one thing I do want to say is that I think it's very important that this first step succeeds in its implementation. So just as, for instance, this first step of adding treatment related to organ transplants and cardiac valve surgeries, if this doesn't get off the ground successfully, CMS is going to be less inclined to keep expanding. So one thing we really need to do is encourage more enrollment of providers to help make this successful, and increase access through the new coverage, and also educate transplant centers, cardiac care centers, and really encourage them to try to do outreach to their local state, dental associations to encourage more enrollment so that we can actually serve beneficiaries through this benefit. So.
I think that makes a lot of sense. We've got 20 minutes left. think like key to that implementation success is to be taking baby steps and talking about this and communicating about it more broadly. Do we want to take the next 20 minutes to think about what those communication channels look like? Or not channels so much as messages? No one's on camera, so I have no idea if people think that's a good idea or not. Which is fine. I'm gonna keep plowing ahead unless I hear from somebody else, because the only people I can see are Gary, Bianca, Melissa, and Wei Wei.
We're all for it.
Yeah.
Okay, so, and Grace, hi Grace. I know that there's and by they, I mean sort of vaguely, somebody is taking the reins on drafting a kind of boilerplate message. Is that correct?
So there's several things that have been drafted that could be purposed or repurposed. I think there's a lot of like advocacy language out there of the various national coalitions working on this, essentially saying, thank you for doing this. This is what's in it. Let's make it stronger and implement it, basically. There's definitely boilerplate language to that end, and there's language that's gone out, within Open through creating connections yesterday and to this group yesterday. That's all very basic. I think what we can do next, but have not yet done, is the more in-depth sort of like, talking, that could be sent to all. I'm trying to think through exactly who the right audiences are that we need to solve for. One, I think, is like making sure we have something very clear to educate, like within Open, that's very much like at an advocate level. This is what this is. Thank you for your activity so far. Let's work together to make it even better over time. But then that could kind of potentially link out to a summary of what the rule is and how to talk about it with beneficiaries. But there's kind of a number of pieces of having to solve for both the advocate letter that explains like why we even care right now, but then also explaining what the rule is and how all of that's different than how we talk about it with people. Right.
So is the initial message, and Grace, I see your suggestion about a kind of ad hoc group, which I think makes a lot of sense. And so do all of the people who I can see. But I'm wondering if the general communication is really just, Melissa, exactly what you said, that's going out to the broader group and includes very clearly Wei Wei's language that this is not Medicare. This is not dental for everyone in Medicare. This is awesome. This is not Medicare for everyone or dental for everyone in Medicare, and more to come, and to, follow this Open channel or whatever, or join this work group or whatever for continued information. And then that smaller group, because it's more than messaging. It's also just like, what do we need to do to work with the dental associations in our state to help make sure that we're kind of countering any negative messages that might be coming from that group, and that they're understanding how they can become providers and what those steps are. And then with the beneficiaries as well, like it's straightforward but complicated at the same time. And so I think we needed, I would advocate for it, and maybe I'm not supposed to advocate for anything since I think I'm also supposed to be facilitating, but I would advocate for a pretty general message that is very clear that folks are still unpacking this, with some direction about how they can start to get smarter, and then just ongoing communication from there.
Yeah, Sarah, I agree. I imagine it as a tiered approach, as you were saying. I think because there's been awareness that the final rule is out, I think a secondary message to say exactly, this is the final rule and how you've laid it out. And then I think at the time that, we can link to, for example, to CMA once they have more detailed resources in a centralized place, I think that works well, versus everyone having very detailed and specifics on all their different channels. Because if it seems like things are going to be updated and changing, so I think looking at the leaders of this who are going to have the most up-to-date information, it's important, I think, to link back to that, as we're thinking about that. And then I think it's about the audiences we need to reach when it comes to implementation. And again, looking to Weiwei and Melissa of, what's the correct language, and then using all, the network's connections to get it to who those people are, providers, consumers, et cetera.
I'm curious, Weiwei, if your organization is creating some one-pager on this that we might build off of. And I know this just happened, but
Yeah, I think we will for sure. Just to let folks know, I'm like in the middle of a move. So the movers I moved from New Jersey to Los Angeles this week.
What?
wow.
Yeah. So hello from Los Angeles. So yeah, I'm kind of unpacking the new rule and unpacking my life.
Very nice,
So,
very nice.
But yeah, I think very shortly we'll have more materials and create that link that Bianca, so that people can link to, as Bianca was saying.
Yeah, so I'm happy to provide staff support for this. If folks want to come together to work on this, I'm happy to join a call and, play a primary role in the writing or whatever would be helpful.
That would be terrific. I also offered up some staff support from Catalyst as well to do some newsletter blurb kind of stuff so that we can start to share that high level information, to Grace's point. And then as we get more specific, certainly happy to help with that too.
So who wants to be involved in that? I was hoping you'd raise your hands. Okay, Melissa, Bianca, Weiwei. Anyone who doesn't have their camera on? Oh, Jessamine. Excellent. Others feel free to use that thumbs up function if you want to join also. Pixel 7, I need more than that. Who are you?
I vaguely remember Pixel 7 reintroducing themselves in the chat. Let me see if I can find it. Anna Sumner, Missouri Kidney Program. Thank you, Anna.
Great. So
And I'm seeing some nice suggestions of sort of tactics, particularly in the political realm, in the chat. I do think that's something we'll need to come back to, particularly given that Congress is really not our target and Congress is about to change massively in this election season. Like, I think there are some really important things to do to thank members of Congress that have been supportive of this, that have signed on to letters and that kind of thing. And or to like say, this is nice, but we want more. But I do think our immediate challenge is with the administration. So I think in some of our next steps, we'll definitely want to create an easy opportunity for folks to thank members that have been supportive of this and have been pushing on the administration, and we can make that easy to do. But I think the sort of congressional strategy as it relates to this is sort of a long-term one that we'll want to come back to. So I definitely think we should make note of these ideas in the chat, as I think they will be helpful, but they may not be the first place we start because there's so much to do.
Right. Do we keep these chat comments? I can't read them very well because of my vision, but they look like they're very helpful. I'd like to
we
save
have
them
in the recording.
Oh,
It
great.
also records the whole chat.
Okay.
Okay, so it sounds like we've got an ad hoc communication group forming. Melissa, do you think that this policy NRT is the right group for the kind of ongoing, holding the center on the ongoing communication, making sure that open and the rest of the stakeholders have the tools they need for however we're communicating with the administration and things like that?
I think it is, you know, I'm happy to open it up more broadly if there are folks that don't typically engage with the policy NRT but are invested in this particular piece. But I do think the policy NRT has been doing this sort of thing on other issues and has been, you know, doing the activities in the lead up to this. So it seems appropriate as a place to start.
Okay. And then the existing Medicare coalition to really think through the strategies around the comments and
Yeah.
scientific data and things like that.
Yeah.
And probably I would think offshoots of that too, along with Weiwei's organization and maybe Families is going to do something also about some of that more granular communication to beneficiaries and that population.
We're definitely going to talk about it and figure out what we're doing
Okay.
and find out if and it may, you know, and to some degree I think CMS will be doing some of that too. So
Oh,
some
sure.
of this will be what are we putting out ourselves and what are we making sure they do to be clear.
So does that feel comfortable in terms of the information that folks wanted to gain today and a few next steps?
And
A
if there
warm
are
thumbs
folks
up.
that are like extremely excited about this and want to get more involved in that sort of other coalition we were talking about that has been working on this in depth for a long time, you know, that isn't a closed group by any means. But it is very much in the weeds on this specific issue and it doesn't touch on other ones. So if that's exciting to you, you know, we're happy to get you connected, but it may not make sense for most of us.
All right, so I guess we can communicate offline about the ad hoc communication group. We can all send Weiwei all of the grace and happiness and energy that she needs to unpack her actual boxes. And is there anything else that folks hoped to get out of our time together today? Still have 8 minutes. We could just stay on and chat. All right. Well, congratulations again to the folks that just worked so hard on this and really made it happen. I know implementation is 80% of successful policy, but it's a pretty amazing win to get it even across the finish line to where we are now. So I'm excited to keep working on it and make everybody healthier. And a very happy Friday to everyone.
Thanks, everyone. Great to see you all.
Bye.
Sarah, thanks everyone.
Thanks everyone for all the hard work.